This mini lecture is going to be on chronic kidney disease or CKD. You may also see it referred to as chronic renal failure in some of your textbooks or some other sources. And although the care of the people with end-stage kidney disease usually resides with a nephrologist, the diagnosis and the management of early stages are usually the responsibility of the primary care provider. So you will see these patients coming in with initial symptoms, and then you will need to be making sure that you're doing some testing on them to determine what their problem is. So, CKD is a progressive loss of functioning of the nephrons, and it can lead to end stage renal disease. So, it goes through different stages, as we'll talk about as we get further into the lecture. It most often is a complication of some type of a chronic systemic disease. So, someone who might have diabetes, somebody who has a significant history of uncontrolled hypertension. These are the most common etiologies of the patients who do end up with end-stage renal disease. The time frame for development can be months to years, so there really is not any specific time frame from the time someone has the initial symptoms until end stage. So it's kind of a gradual thing, and you need to be on top of it and making sure that the patient stays within goal because the mortality is kind of high with this. Approximately 160,000 people have end-stage renal disease and are on chronic dialysis. As I said, about 70% of these patients have diabetes and hypertension, and they're usually uncontrolled. They may have diabetes that has been uncontrolled for a long time, and now it's controlled, but the damage has already been done. There can be other conditions too that could cause it, such as polycystic kidney disease, glomerular nephritis, and any other urological problem. You know, somebody who has vascular disease, as well as some type of an obstruction. Some of the risk factors we look at with these patients are the abuse of analgesics, as well as cigarette smoking. This seems to be a big thing with these patients. They have a tendency to be heavy smokers. They also have collagen vascular disease, as well as the possibility of having AIDS-related nephropathies. Some of the patients have cirrhosis, so they also have an alcohol history. And you can also have someone who has non-alcoholic hepatic cirrhosis too, that does have chronic kidney disease. And a lot of times these patients might be diabetics also and have hypertension. So it's a whole kind of a gamut of things that you see with these patients. But if you really look at it, the main factors are the diabetes as well as the hypertension. They may have had multiple myeloma, which will put them at an increased risk, as well as someone who does have polycystic kidney disease. And this is a hereditary condition, and it can lead to chronic kidney failure in children as well as adults. So it is something that we need to keep an eye on, and if we're suspecting that, to make sure that they are being followed by a kidney specialist. Initially, these patients may not really appear very ill until they really start to get a significant decline of about 10 to 15. They may also present with some dermatological issues. So they could tell you that they're getting some itching of the skin. They have very dry skin. They may complain of some GI issues. So they could tell you, I just really have no appetite. I feel like I just don't want to eat anything. I'm nauseated a lot. I've had episodes of vomiting, and I'm also been hiccuping. They could also have some neurological complaints. So they may have some emotional lability or depression. The family members may tell you that they're crying a lot, or they feel very emotional, and sometimes they just break down for no reason at all, or they'll be very quiet and very reserved, and they don't want to really get involved in any type of conversation. As their levels start to change significantly, then they become very confused. They can have headaches and seizures, and even go into a coma state. There are times when these patients come in and they have a urine odor to their breath and perspiration, and many times the family members will tell you that they actually do smell that type of urine on them when they're talking to them. You see this a little more in the later stages when they get into stage 3 or above. You don't see it as much in stage 1 or 2, but it can occur in stage 3. And they also have some complaints of shortness of breath. They feel like they have metal taste in their mouth. And also, they'll tell you that they just aren't able to have sexual relations like they used to have, that they are more impotent than they were. They have difficulty with erectile dysfunction. They get up at night to go to the bathroom. And then some patients also get muscle cramps and foot drop, as well as can develop an infection. And they may have a tendency to come back with gout. And they have gout over and over, have episodes of gout. And so they're coming into you for treatment for this. These patients present in the office and they look pale. They might have a uremic frost appearance to their skin, which you see more when they get into the later stages of CKD, such as at 4 or 5. But they also could have some bruising, and then they may also have peripheral neuropathy, which they could have from the diabetes also, as well as some altered mental status. Now, the altered mental status would occur more in the later stages also of CKD versus the earlier stages, as well as peripheral edema and ascites. So we have to be thinking about cardiac issues that can be going on with these patients also, because they do have a risk of adverse cardiovascular events because of the increase in the occlusive coronary disease, and because of the risk that they have with arrhythmias and heart failure and even sudden death. So during the early stages of CKD, the risk equals that of persons with known heart disease and increases if somebody goes into dialysis. So we always have to be concerned about somebody having cardiac issues going on, as well as their kidney issues. We're going to hear some oscillatory cracks and pericardial rub, and that's also another thing we need to be concerned about with cardiac going on, as well as their blood pressure being elevated. They may get tachycardic, and they may have some accumulation of some toxins, some toxic metabolites, which could be caused by some substances that are being produced by the kidney. There are 5 stages to chronic kidney disease, and you're going to need to know these stages, the stage 1 through 5. In stage 1, there's really a little bit of damage that could be going on with a normal GFR. So if they're over 90 in their GFR, they might have some kidney damage with mild changes to the GFR if it's in the 60 to 89 range. Moderate would be 30 to 59, severe would be 15 to 29, and then go into a full-blown renal failure. So as we talked about some of these symptoms that they have, until they really get into that 4 or 5 range, you may not see uremic frost, and you may not see some of the other things going on with these patients. But usually by the time they're at CKD3, they're being monitored by nephrology, and they should be monitored by nephrology at this point. So if a patient has a condition known to predispose them to the development of chronic kidney disease, such as diabetes, they need to be coming into your office every 3 to 4 months, having their chemistry panel monitored with the BUN and the creatinine. And most insurance companies now are requiring a documented microalbumin with creatinine and protein with every diabetic patient once a year. The serum creatinine tracks that progression of the disease, and it's very important to be doing that on every single one of your patients. But the GFR can fall to about 40 to 50% of normal with only small changes in the serum creatinine level. So it's really important to be monitoring the GFR as well as the serum creatinine. The GFR can be estimated using the Cockcroft-Gault formula for creatinine clearance. And although it trends the levels, really the lab work that you get back on your chemistry panel kind of has already done this for you, so you're not going to have to go in and do all these calculations. One of the things that is important is to realize that trends in the GFR are far more important in assessing renal function and the stability of CKD than are the absolute values of both of these indices. When they looked at 13 different studies, they realized that a lower GFR and a higher albuminuria independently do predict mortality and end-stage renal disease in patients with CKD. So it's really true of direct serum creatinine measurements because those interpretations take into account the patient's age as well as their muscle mass and their gender. Creatinine clearance is definitely a far more informative diagnostic tool as a measure of renal function. We don't have a universally agreed on definition of chronic kidney disease. The GFR and the proteinuria are often used to stratify CKD patients by disease severity, which is why they came up with those stages as we saw on the previous slide. And so when you're looking at renal functioning declining, then you have to be looking closer at monitoring other electrolyte imbalances and, detecting whether there's something else going on, such as hyperkalemia. There can be numerous lab alterations in patients with an end-stage renal disease. When we're looking at the CBC can reveal either a normochromic, normocytic anemia. There could be decreased hematocrits. There may be increased bleeding time, thrombocytopenia, a decrease in the immune response. And then blood chemistries can reveal that there's decreased activity with vitamin D as well as an elevated ammonia level, BUN, creatinine. Your uric acid levels change. Urinalysis could reveal that there is protein. Ketoacidosis may artificially raise the creatinine levels, and certain drugs such as cimetidine, which is Tagamet, or trimethoprim, which is your Bactrim, may also alter diagnostic test results. When we talked about the 24-hour urine studies, we're looking at protein as well as creatinine clearance, and those are usually difficult to obtain in ambulatory patients and have been largely replaced by spot urine checks. But the majority of patients now, if you give them a 24-hour urine container and you explain to them what they need to do, they will go ahead and do it. And now with the addition of the microalbumin in the urine, it works very well to get some of those results back. Also looking at the complement levels as well as ANA serum and then the urine electrophoresis, protein electrophoresis. Kidney ultrasounds are performed at least at baseline, which is really important to do. If you suspect someone's got something going on, go ahead and get a kidney ultrasound on them for a baseline. And that ultrasound can look at the kidney size. It can tell you if they've got polycystic kidney disease, if they've got some type of an obstructed ureter or bladder outlet. You can also do a renal CAT scan or angiography or even an MRI or an MRA. And that can help look at visualizing the structural abnormalities as well as the renal artery stenosis. But renal angiography remains the diagnostic gold standard for CKD. Renal biopsies, you don't see them doing them much anymore for CKD as much as you do for acute renal failure. Because acute renal failure, they're really trying to look and see what is going on immediately with that patient. With CKD, they're coming in with, already having other chronic illnesses such as the diabetes and the hypertension. But with acute renal failure, it could be just something as crazy as the patient took tons of Motrin and now they're in renal failure. So it's not really used as much for this, and it really is not, unless non-invasive modes are unable to really tell the nephrologist what is going on, they try not to use it. So, how are we going to manage this patient that comes in? What are some of the general principles of management? Well, we need to determine and control the underlying etiology. So, if they're a diabetic patient, we need to make sure that their levels are staying down, that their blood pressure's in control, that we're monitoring them very carefully, monitoring their kidney function. Glucose levels and hypertension have to be strictly controlled in patients, and we really want to try to get their A1C levels less than 7% if we can do that. And if they have proteinuria of more than 1 gram a day, then we need to make sure that we target their blood pressure to be about 120 over 70, 125 over 75, something for that. If they have less than 1 gram a day, then you can have their blood pressure a little bit higher in the 130 over 80 range. Um, Instituting more aggressive treatments such as dialysis is really kind of reserved for the later stages, so we're not really going to get into that with unless they're in a 4 or 5 level. ACE inhibitors, the angiotensin converting enzyme inhibitors, or the newer class, which is your ARBs, which is your angiotensin 2 receptor blockers, they should be used for blood pressure control in patients with diabetes because they are renal protective. So every single patient really that has diabetes should be put on an ACE or an ARB, and it is really the standard of care to do that. If you do need to do monotherapy with one of these agents, you don't need to do both of them. You can just maybe add a diuretic or something like that if you need to do that, followed by a calcium channel blocker or even a beta blocker. All the nephrotoxic agents, as you can imagine, should be avoided. So we need to be very cautious about, anything that could be destructive to the kidneys, thinking about other things that we are prescribing to the patients. We can give them skin moisturizers for the dry skin. We can give them Benadryl or some type of an antihistamine to treat the itching of the skin. And then they're going to be starting to go to nephrology. Um, as the CKD progresses, they're going to have increased difficulties with fluid balance. They may be getting hyperkalemic. They may get acidotic. Could get severe uremia. And they really need to be monitored by a specialist so they can be checking their rate of progression. And the progression to kidney failure is really going to depend on the underlying renal disease. It's, as I said, it happens more rapidly with someone who's a diabetic or someone who has severe hypertension. So it's very common to see these patients there. You'll start to see maybe their creatinine levels start to rise just a teeny bit, and their glucose levels or maybe their A1C levels are in the 8%, 9% range. It does not take long for someone who's got elevated A1C levels to start bumping up that creatinine, boom, boom, boom. And then before you know it, they're in CKD2. So monitoring them is going to be the critical thing. But when you send them to the nephrologist, that is going to be their job also. But you also don't lose onus on the patient when they come back to you for anything, because you still should be making sure they're going to the nephrologist, making sure that they are uh, following everything they're telling them to do, that they're getting their blood work done by them. And most of the time, the urologist is running a gamut of blood work every 3 to 4 months on these patients. But it's usually more rapid, as I said, in these patients with diabetes. So that has to be in your mindset all the time. They may need to be hospitalized to control their fluid overload or to, manage their hypertension, or if they have hyperkalemia or any type of infection. But the most important thing, as I said, is monitoring and treating all of these underlying disorders that can lead to the chronic kidney disease. Patient education is so important with these patients because they just don't understand what's happening, and the family needs to be involved. This is where your family health theory really comes into play, because they need to be involved in the patient's education and the patient's care. They have to have a really good understanding of the chronic and progressive nature of CKD. of the importance of making sure that all of these underlying chronic problems are under control, making sure that they're not getting an infection anywhere, that they're getting healthy diet, and that, they should know that if they see their urine output going down, that they're bleeding, they have nausea, they have vomiting, then they need to be seen immediately by the primary care specialist or even the nephrologist if they're being treated by them at that time.